So hello everybody. My name is Dr. Atif. I am a postdoctoral fellow in telepsychiatry here in NIMHANS, and today the lecture we'll be talking about is low intensity psychological interventions, also known as Lippy. So just to get an introduction, the what is Lippy? So low intensity psychological interventions. So by low intensity we mean that it is requires less resources and it can be done in a primary care setting. So these are psychological interventions which can be done by non-specialists in primary care settings in a limited period of time. And why do we require this? So first of all, we know that there is a big mental health gap and there is lack of time in primary care setup and there's need for holistic treatment. So by this, generally when patients come, most of them, as you might have realized by now, seem to require psychological interventions, but you always cannot refer to a psychiatrist and you also cannot spend so much time with the patient. So it's very important that they also get the full treatment. That's why these Lippies would be something that you can use in your primary care setup uh, in for giving better treatment to your patients. So what are the components? So in this module, we'll only be talking about the individual therapies. So these will be brief therapies which are not more than 6 sessions. There can also be group therapy, self-help material, and internet-based interventions. However, we'll not be talking about this here. And on the right, you can see over here is the WHO manual, Thinking Healthy, especially for postpartum women. This gives a good tip for how to give these psychological interventions to these women, and this could be a good reading after the lecture. Now, next the question comes, who can you give these psychological interventions to? So generally, as a rule, remember, the patients which you see in the primary care setup, most of them will have mild symptom severities and high prevalence conditions like depression or anxiety. So these are generally the patients who you can give Flippy to. If it's very severe illnesses, then it's better to refer for higher centers. And also, you can target specific clinical problems. So by this, we mean that suppose a patient comes with anger discontrol or sleep disturbances. So for those specific clinical problems, no matter what is the diagnosis, you can use these low intensity psychological interventions. So how would you administer? So there'll be 4 steps basically. First, you'll explain the purpose and structure, then you'll do an assessment, then you'll formulate the case, and finally you'll apply these interventions. But before you begin, there is some things you need to remember. First, as we discussed before, choose an appropriate problem. If it's moderate to severe illnesses or you're trying to do something which is too much, then these low intensity interventions will not work. Second, very important for any psychological intervention is that the patient has to participate. That is required. Participation from the patient is essential. And lastly, building rapport. So by rapport, we mean that you need to create an environment where patient will feel that they have control, they know what is going on, and they are well informed over the treatment. Only then they will actively participate. So first step is explaining purpose and structure. So what you'll do is every step you will tell them what you will be doing in the next 5 or 6 sessions. You'll tell that it will be half an hour sessions and it will be only 5 or 6. It will not be more than that. And again, you will reiterate to them that they need to actively participate in each and every step. So first and the most important session will be the assessment. So generally, when you are assessing any client's problems, any of the patient's problems, you remember the 5 Ws. By that we mean what, who, where, why, when. So suppose a patient comes with uh, anger discontrol. So you'll ask uh, what occurs during the problem situation. So what occurs before you get angry? What will cause you to get more angry, or what will cause you to get less angry? So like whom does the problem involve? So who makes you angry? Who will make you less angry? Where? So you'll be asking, where do you generally seem to get angry? Where does this thing happen? And where do you not get angry? So is it in the home? Is it outside in the office? Then why? So generally we don't ask direct why questions. So that's why it's like, what is the clinical client's understanding of why the problem happens? So in our example, uh, what does the patient feel? Why does he get angry so frequently? And when? So when is the problem most and least likely? So when does the patient likely to get angry, and when is it least likely that he'll get angry? Next, like a medical history, you'll also consider onset, frequency, intensity, duration. So again, fitting it into our earlier thing, we can ask, just before you get angry, what is happening? How often are you getting angry? How much problems in your life are coming because of you getting angry? And when this problem happens, when you get angry, how long does it last? Using all these assessments, you'll basically come to a formulation. Formulation is nothing but your understanding and the client's understanding of what's going on. It's a here and now approach. So we are seeing right now what is the issues that the patient is having in his life. Of course, it's the patient is the person who is going through the problems. It's a collaborative process where the patient will and you will get together, and you will make this formulation, and it will be a process by which you will help them to guide their link their thoughts, emotions, behaviors, body sensations, and the triggers. So they'll get a complete understanding of the problem, how it has started, and how what are the factors which are maintaining it. So, for example, taking our previous example again, the suppose the problem is that the trigger situation is the patient's above mentioned patient's child failing in the exam. So, the thoughts that the patient is having is that my child will become a failure, or my child does not respect me. I am a useless person. I cannot make my child study. So those thoughts he is having, this is leading to him getting angry. This is causing him to scream and shout. This is causing him palpitations and heart pounding faster, hand shaking, which is causing more anger and anxiety. And this is causing him to shout and hit at his child, shout and hit at his wife. So you can see that that is how a formulation will come up. So you'll be able to link how the trigger situation is causing thoughts, which are causing emotions, which are leading to body sensations and behaviors, and how all this is interlinked. So you will be able to come up with a clear treatment that in this case, we need to correct these thoughts and we need to correct this behavior. So you can come up with a treatment plan based on this formulation. So this is just another formulation of depression. So there is a gentleman who is now coming with sleep problems, excessive tiredness, and fatigue. And basically, his thoughts are, I am a failure. I am not able to cope at work. I am worthless, which is causing him a lot of guilt and shame. And this is causing him headaches, nausea, sleep disturbance. And because of this, he's not going to work, sleeping all day, not eating. And this is again leading to all these thoughts, emotions, and body sensations increasing. So this will be a sort of a formulation which you can come up with. Always assess for suicide risk. I think in the broad headings of intent, plan, action, prevention, risk of harm, this will be covered extensively in another lecture for suicide risk assessment. So we'll not go into much detail, but if you feel that the patient has suicidal risk, always refer to a higher care center. At end of this assessment, you will decide whether you feel that the client is suitable. Sometimes you'll feel at assessment you'll feel he has a more severe illness than you thought, and at that point you should refer. You will choose modality. So you'll see, I'll do these anger control methods or I'll do cognitive restructuring. You'll be able to link the problems, that's the issues he's having, with his goals. So suppose he has anger discontrol. So his goals will be not to get angry. You will be able to make a structured treatment plan. So what you will do in each session, you will be able to decide, and how you will measure how the patient is improving or not. Goals should be specific, measurable, achievable, relevant, and time limited. This again is very important because you can realize that you want to come up with goals which are achievable. If you uh, if you are trying to do too much, then the intervention will be unfocused and you will not be able to finish it in time. So suppose a patient is coming with depression, with sleep disturbances, he's not eating well, he's not going out. So what you can do is you can make a goal achievable. So his goal could be that he is able to go out and go back to work. Measurable would be to see that how much hour he spends at work each day. Is it increasing? Of course, it should be achievable and within reach. It should be relevant. So now he's not going to work, he's not getting money, right? So he needs money. So it should be relevant to the client's life. And of course, it should be time limited. So it should be ideal that you should be able to get short term goals. You cannot change his whole thinking pattern or his lifestyle, but going back to work, sleeping properly, eating properly, those are the goals which you can achieve in small period of time. Now, importantly, we'll come to the tools and techniques, the things which you will actually use for administrating this Lippy. So, first and foremost, most important is psychoeducation. So, this is quite important and it can be done for all illnesses. Remember, psychoeducation is sharing of information. That's how the etiology is, what is maintaining it, what are the symptoms, and what will be the future consequences of a particular clinical problem. So you will tell them everything about depression, how it's been maintained, what are the symptoms, what are the consequences, what are the predisposing, precipitating, perpetuating factors, and most importantly, there is medicine and treatment and prognosis. This is very important because many times patients will come and especially in the primary care settings, they'll have this stigma that, or their family will have this stigma that they are just acting, or there's nothing like depression, they can just get happy. So all these things will sort of, you need to bring that it is a medical illness and there are treatments. It's not a shameful condition, or it's not like the patient is deliberately doing it. And many studies have shown that just this psychoeducation will provide symptom relief to the patient, improve treatment outcomes, treatment adherence, and functioning. So this is a very important step. Another thing is motivational interviewing. You'll learn about this more in your brief interventions for alcohol use disorders. But basically, many times patients will come where they will have low motivation for change. That's okay, I might do this also, I might not do this also. Classically, in patients who are alcohol dependent, they'll say, I might stop also, I might not stop also. So they'll have this sort of ambivalence. So generally, there is the DARES model, where it's developing discrepancy, avoiding arguing, rolling with resistance, expressing empathy, and supporting self-efficacy. That's how you do motivational interviewing, and you learn more about it later. And the techniques you use are OARS. That's open-ended questioning, affirmation, reflective listening, and summarizing. All of these have been previously covered in your lecture on counseling skills. And there's one more thing, is a decisional balance worksheet. For this, you can use for addressing the ambivalence. Basically, what you can do is taking the example of an alcoholic patient. So, what will be the benefits of stopping alcohol? What will be the disadvantages or the costs of stopping alcohol? What will be the benefits of not stopping alcohol? And what will be the disadvantages of not stopping alcohol? And generally, they will see that the benefits of stopping and disadvantages of not stopping are much more than the benefits of not stopping and disadvantages of stopping. So that will help them only make a change. However, remember that you don't have to fill this. You have to give this to the patient to fill this themselves. If you fill, it will be like forcing them to do this. And as we talked, active participation from patient is the main thing. If they want to make a change, they have to come up with this themselves. Next, we come to self-monitoring. So, self-monitoring basically means that they can monitor what's going on with themselves. So, uh, basically, you can ask them to keep diaries. So, suppose a person has social phobia, social anxiety. What happens is they are going into a situation where they'll walk in front of a group of people. They'll think, oh, they are talking about me, they are laughing at me, they are judging me. This will cause them anger, anxiety, fear. So what they'll do is avoid going through that place, avoid uh, not going there. They'll have difficulty in doing the work that they're trying to do. So this would be something they'll identify themselves. What you can do is you have to replace this thought with the alternate thought that, oh, they could be talking about anything. They could be laughing among themselves, joking among themselves. I can go ahead and ask them later always. Similarly, you can ask the patient to keep situations where they are having problems, what thoughts they are having, what emotions they are having. This can be done for mood as sleep as well. It will help patient become self-aware, and also you can see over the period of your Lippy how these things change and how these alternate thoughts slowly start replacing the thoughts they are having. Cognitive restructuring, again, a simple thing to explain to your patients is that if you go to a roller coaster ride, if you go to a theme park where there are roller coaster rides, there will be two people. One person will see the roller coaster and he will be very excited. He'll go on the roller coaster and enjoy it, have a fun time. The second person again will see the roller coaster. He'll start feeling scared and he will not go on the roller coaster. He'll sit on the side and he'll not have such a good experience. So there are two people seeing the same situation, but two of them have a very different experience, right? So why is that? That has to be because their thoughts are different. The one person is going and enjoying the roller coaster, other is having thoughts, so what if I fall off the roller coaster? What if I get injured? What if I vomit? All those things are making him anxious and he is not going. So these are the negative thoughts. Basically, what we do in cognitive restructuring is you identify the negative thoughts. Then each negative thought you find evidence for and against this thought. Like how many times has it happened that somebody has fallen off the roller coaster and died? How many times has it happened somebody has gotten sick over there? Why am I getting this thought? So you find evidence and finally replace it with another thought. That is the basic of how cognitive restructuring works. It's much more in detail, but I think in Lippy, this is all you need to know for now. Behavioral activation, something you can do again. Basically, what happens is people who get depressed will feel this easy fatigability, which we talked about, the low energy. So they will not go out, they'll avoid everything and they'll become socially isolated. So if they are not going out, staying at home, they'll not have good experiences. And whatever those negative thoughts were, right, they'll not be able to challenge it. They'll not be able to generate alternate thoughts. So you can basically ask them to follow a worksheet, a behavioral activation worksheet where loosely they can come up with again, they have to do this themselves. They can write the days, time, and they can fill up what they want to do during this period. And it can be very, it can be very loose at the start, doesn't have to be very strict. What they can do is put activities which give them pleasure. So they can go ahead do it. And second, they get a sense of mastery. Basically, gardening or practicing guitar, going for walk, things which will give them a sense of purpose. So even if they do it small initially, they'll be able to challenge their negative thoughts. That is the whole thing. Again, ask the patient to make this themselves. Uh, some now stress management techniques are also quite commonly we can use. One is yoga, other is breathing retaining techniques. So basically, I can ask them to take deep breaths, because when people become anxious, they start hyperventilating, which increases anxiety further. Taking deep breaths at that time can help them. Muscle relaxation techniques, again, what you can do is sit on a chair, and then starting from the face, arms, shoulders, and legs, they can tense the muscles and relax it slowly while focusing on these sensations. And finally, they can breathe in and breathe out. Uh, Exposure therapies, again, will not go much in detail. They just, you need to know, in anxiety disorders, they'll make a hierarchical list of anxiety provoking situations. And so basically, if somebody has social anxiety, for them most anxiety provoking will be going on stage and speaking in front. Least might be sitting in a meeting and asking a question. So like this, you ask them to make least to most anxiety provoking situations, and then you start from the least and expose it to them and ask them how they felt afterwards. So if they ask the question, what were their thoughts, how did they feel, how were their body sensations, you record all this. And like we talked before, you can try to challenge these thoughts and change the behavior. Interoceptive exposures, again, in people who have panic attacks, they can have they have tachycardia and tremors, and which they misinterpret as something very dangerous happening to them. So you can remove this association between tachycardia and danger in the hospital itself. But again, these are not very amenable for Lippy per se. Behavioral experiments are outside the clinical setting, so those would be like how we talked about, going outside, going and asking a question. And they'll have this expected outcome would be that I will mess up the question, I'll do very badly. Observed outcome might be that they do well. So that will create a discrepancy. Sleep hygiene, again, very important. Keep a regular, there's something, sleep hygiene means you increase the things which will promote sleep, and you decrease the things that disrupt sleep. Basically, promote sleep would be you ask them to keep a regular sleep schedule, uh, get up and wake up at a at a fixed time, create a relaxing bedtime routine. So that means no tablets or phones or televisions. Bed should only be for sleeping. Can take a hot shower or mild warm bath before bedtime. Bedroom is sleep friendly, no noise. It should be dark and cool and comfortable. If they should not have, they should eat and drink correctly. Basically, no big meals at night, no caffeine or alcohol, and don't take too much liquids close to bedtime. And night, they can, if they're not sleeping, they can close eyes and take slow, deep breaths. They can do those relaxation or deep breathing exercises. And importantly, ask them to, if they are not able to sleep, you can ask them to uh, take a small walk for 10 minutes and come back to bed again when they start feeling sleepy, but not to use mobiles or think about stress inducing topics of the next day. uh, Problem solving techniques, generally what happens is people, when they are trying to solve problems, they will worry rather than coming up with solutions. So if they, suppose they lose their wallet, they will think, oh, I lost my money, now somebody will steal my credit card, somebody will steal my money, what will I do, I'll get ruined financially. So they'll start thinking on all the negative things. Problem solving would be that you think about solutions rather than the negative things. So you start thinking, okay, now I can file a police complaint, or I can go and search for the wallet, I can cancel my credit cards. These are all solutions, and then you'll take a positive and negative of each solution. After you take a positive and negative of each solution, you will take the top 5 solutions and uh, do again an advantage disadvantage. Finally, you'll decide on 1 or 2 solutions. Okay, I'll go and contact the police station and I'll cancel all my cards. Then who will do it? I will go and do it. My family member will do this when? Today evening and right now. So you will write when you will do it, who will do it, and how you will do it. Then you'll implement, and then you'll see the effectiveness of the solution. And later you can see, okay, if suppose you found the wallet before, so you can cancel the step about without the cards. So you can cancel about going to police station and just block the cards. So we'll see as time progresses, you can revise the plan. These are basic problem solving techniques where the patients can, instead of worrying, they can be taught how to come up with solutions for their problems. uh, Almost last now we have reached is the assertive communication. Many times patients will say nobody listens to me, or everybody, walks over me. I'll not get my thing done anytime. I am very low self-esteem. So basically, we teach them assertive communication. That is that they have to recognize how to put across their point in a way that they are able to tell the point clearly and confidently, and they can get their needs also done without giving too much or taking too much. So it's like it's a way to fairly put your point across, and it will help them to build up their own self-esteem. Some tips for assertive communication is using I statements. That would be like, I would like you to give me a refund. Okay, I think what you have done is good, but I want to see more of you coming on time. So describe how other person's behavior is making you feel so that other people become aware of the consequences. So you can tell, when you don't tell me what you are feeling, it is making me confused. When you are raising your voice, it is making me scared. I would like to speak. I would like you to speak softly. And finally, there's the broken record technique. So you keep repeating things till you get your point across. Especially important for people who use substances, who tell their friends will force them to take alcohol. So you can keep repeating, I don't want to take alcohol. I know it's not like that. I don't want to take. I know what you are saying, but I don't want to take alcohol. So like how a record player which is broken keeps on repeating. Similarly, you can just keep on repeating these things again and again. That just so that you can get your point across. Anger management techniques, some basic ones are reverse counting from 20 before you say anything. Basically, remember that anger is an emotion which peaks for 10 to 15 minutes and then comes down. So for those 10 to 15 minutes, you can teach them techniques to control their anger. One would be reverse counting. Next would be deep breathing. They can take out their anger on non-living things like punching the pillows in their bedroom. They can take a 5-10 minute walk before responding. Basically, you are leaving the situation where you are being provoked. So if you are away from the situation, you will definitely not respond. Uh, Before they respond, you can mentally challenge yourself. So can go, what is the source of my anger? How much anger is there? Why am I even getting angry at the other person? Suppose the other person went through my situation, would in and got angry, how would I feel? How would I want to be treated? And you can also write out a response in the diary before saying it orally. So again, these are some things which can help to control the anger. Finally, you'll terminate the Lippy in 3 to 5 sessions, 6 sessions maximum. Last session, you'll revise goals which they have achieved and how they can achieve more further, address any anxiety, fear, sadness which might be there, and we can try to follow up if possible. So that was the lecture. Thank you very much. And in any doubts, you can email us on the link provided.